Hypothesis: successful eradication of H. pylori is a euphemism for coccoidization, and intestinal metaplasia-associated carcinogenesis is driven by intracellular coccoids. Authors: A. Clinician, MD, PhD, corresponding author, Department of Gastroenterology, Somewhere General Hospital. Abstract: despite apparent successful eradication of Helicobacter pylori based on negative urea breath test, stool antigen, and culture, gastric cancer risk remains elevated, particularly in seronegative individuals with advanced atrophy/intestinal metaplasia, Group D of the ABC screening system. We propose two provocative hypotheses. Hypothesis 1. What is clinically defined as successful eradication often represents successful induction of the coccoid form of H. pylori, a viable but non-culturable dormant state. Current eradication protocols, PPI/PCAB plus antibiotics, promote coccoidization by raising intragastric pH and altering the gastric flora, leading to false negative routine tests. Hypothesis 2. In intestinal metaplasia, IM, surface Lewis B antigen, the canonical H. pylori receptor, is lost, making the organism undetectable on the luminal surface. However, intracellular coccoids residing within IM epithelial cells can persist undetected, periodically resuscitating to inject CAG via type 4 secretion system, thereby providing a long-lasting carcinogenic stimulus. This explains the paradox that ABC Group D, antibody negative, atrophy/IM positive, carries the highest gastric cancer risk. These hypotheses challenge the current eradication paradigm and have immediate clinical implications, including reconsideration of long-term PPI/PCAB use and a potential role for H2 blockers in maintenance therapy. Introduction. The discovery of H. pylori and its causal role in gastritis, peptic ulcer, and gastric adenocarcinoma led to global eradication campaigns. However, a troubling observation remains: gastric cancer still occurs after successful eradication, and the highest risk group, ABC screening Group D, is antibody-negative despite advanced atrophy/IM. Conventional wisdom holds that H. pylori cannot colonize IM mucosa due to loss of Lewis B. But if the bacterium is truly absent, why does cancer risk persist and even peak in this group? We offer a heretical answer: the bacterium is not absent, it has simply gone underground, both morphologically, coccoid, and spatially, intracellular. Hypothesis 1. Successful eradication equals successful coccoidization. 1.1 The coccoid form, a viable but non-culturable state. Upon exposure to antibiotics, acid suppression, or nutrient stress, H. pylori converts from spiral to coccoid morphology. Coccoids are metabolically reduced but viable, demonstrated by resuscitation in animal models. Are not detected by routine culture, urea breath test, or rapid urease test. May show negative or low-titer antibody responses. 1.2 PPI/PCAB as coccoidization promoters. Powerful acid suppression, PPI/PCAB, raises intragastric pH to near neutral, which facilitates bacterial overgrowth, the milky white gastric fluid. Creates a hostile environment for spiral H. pylori but selects for coccoid transformation. Is routinely used before eradication therapy, inadvertently priming the bacterium to enter dormancy. 1.3 Clinical corollary. A patient with negative post-eradication tests may harbor viable coccoids in the gastric mucosa or even inside epithelial cells. When acid suppression is withdrawn or dietary triggers, e.g., vitamin C from salads, appear, coccoids can revert to spiral forms and reactivate CAG injection, mimicking reinfection but actually representing endogenous recrudescence. Provocative statement: most reinfections in adults are not new infections but reactivation of previously eradicated coccoids. Hypothesis 2. Intestinal Metaplasia-Associated Carcinogenesis is driven by intracellular coccoids. 2.1 The Lewis B paradox. IM mucosa lacks surface Lewis B antigen, the primary adhesion receptor for H. pylori. Consequently, standard biopsies and tests fail to detect the bacterium on the luminal surface. This has led to the dogma that H. pylori cannot colonize IM. 2.2 Intracellular coccoids, the hidden reservoir. However, H. pylori possesses a type 4 secretion system, T4SS, capable of injecting CAG directly into host cells. Multiple studies, both in vitro and in vivo, have documented invasion of gastric epithelial cells by H. pylori. Intracellular survival in a coccoid-like form. Evasion of autophagy and lysosomal fusion. We hypothesize that IM cells, despite lacking surface Lewis B, can harbor intracellular coccoids that entered prior to IM development or via basolateral routes. Once inside, they remain dormant, shielded from immune detection and antibiotics. 2.3 Periodic resuscitation and sustained CAG signaling. Coccoids may sporadically resuscitate to a metabolically active, but still intracellular, state, allowing continuous or intermittent CAG delivery into the host cytoplasm. CAG activates procarcinogenic pathways, SHP2, PAR1, beta-catenin, NF-kappa-B, over years or decades. This provides a direct explanation for persistent cancer risk after successful eradication. Highest risk in ABC Group D, antibody negative, advanced IM, no surface bacteria, no antibody response, but intracellular coccoids silently driving carcinogenesis. 2.4 Comparison, Group C versus Group D. Feature. Group C, AB+, atrophy+. Group D, AB, atrophy+. Surface H. pylori. Present. Absent, no Lewis B. Antibody response. Positive, chronic stimulation. Negative, no surface antigen. Intracellular coccoids. Possible. Likely abundant, long-term residence. Carcinogenic drive. Inflammation plus CAG. CAG from within, stealth. Cancer risk. High. Highest. Unified model and clinical implications. Integrated hypothesis. Eradication therapy, PPI/PCAB plus antibiotics, convert spiral H. pylori into coccoids rather than killing all organisms. These coccoids can survive intracellularly, particularly in areas of IM. Loss of surface Lewis B in IM renders the patient seronegative, ABC Group D, but intracellular coccoids persist. Periodic resuscitation CAG injection sustained carcinogenic signaling, highest cancer risk in Group D. Clinical predictions. Long-term PPI/PCAB use increases the risk of coccoidization and thus, false eradication. H2 blockers, e.g., famotidine, with milder acid suppression, may reduce coccoid formation and serve as better maintenance therapy after eradication. ABC Group D patients should not be reassured that the bacterium is gone. Instead, they may benefit from surveillance and consideration of anti-coccoid strategies, e.g., longer or repeated eradication, autophagy modulators. Therapeutic redirection. Current test and treat and test and eradicate paradigms need revision. Negative tests do not prove absence. Novel diagnostics targeting coccoid-specific antigens or intracellular DNA are urgently needed. Until then, H2 blockers for maintenance and avoidance of unnecessary long-term PPI/PCAB are prudent. Limitations and future directions. Proof of intracellular coccoids in human IM tissue is technically challenging, electron microscopy, in situ hybridization. We call for targeted studies. Resuscitation triggers, dietary vitamin C, cessation of acid suppression, need systematic investigation. Animal models of IM with intracellular H. pylori coccoids should be developed. Conclusion. We propose that clinical eradication often means morphological and spatial hiding, not elimination. The highest risk gastric cancer group, ABCD, may be explained by intracellular coccoids that silently inject CAG for decades. If correct, this hypothesis demands a fundamental rethinking of H.pylori management, including a retreat from universal long-term PPI/PCAB and a revival of H2 blockers in maintenance therapy. Doya? As our endoscopy nurses would say, this is the uncomfortable truth hidden in plain sight, wrapped in a cartoon of a salad and a syringe. Acknowledgements. The authors thank the endoscopy nursing staff for their sharp eyes and sharper wit, without whom the breast augmentation like tense polyps and milky white gastric fluid would have remained mere observations rather than clinical clues. Conflicts of interest. None. The authors are not paid by H2 blocker manufacturers, but they are tired of seeing PPI-induced fundic gland polyps.